Hello, my name is Dr. Marleine Clay. I am an emergency medicine attending. I work at INOVA Fairfax, which is located in Northern Virginia, part of the DMV area in Washington, D.C. We are a level 1 trauma center, and we see nearly 300 emergency department visits a day. Today, I would like to talk to you about BrainScope, which is an exciting new technology. It is a handheld device that uses EEG algorithms to assess for structural injury and concussion. I do have a disclaimer. I am a BrainScope consultant. However, I was asked to look into BrainScope over a year ago to see if it would help in the throughput of our high volume emergency departments. So we conducted a study, we conducted a pilot program in our emergency department, and I was not a consultant for BrainScope at that time. After the completion of the pilot, I started doing consultant work, but it was not pertinent during any of the study or pilot program that we did at Fairfax. So I'd like to speak beginning with the traumatic brain injury numbers that we see in the United States. We see 53% of patients in the emergency department with mild traumatic brain injuries. It's interesting to note that the second highest percentage are patients who choose not to seek any care, and that's at 17%. It's followed by a tie between patients who go to the urgent care or have injuries at sporting events at the sidelines, and those are both 11%. Of those 53% that come to the emergency department, that comprises 4.8 million visits. And we order 4 million head CTs for that 4.8 million, which is a really high number. And that means we are ordering way too much head CTs. And what this means for our throughput is, of course, increased length of stay, increased radiation, increased cost for patients and the health system. And without much patient satisfaction, they usually leave dissatisfied. And the experience between providers and patients is also dissatisfactory, with less one-to-one time and a more frustrating visits. This has caught the eye of ACEP as well. They have endorsed the CMS implementing AUC guidelines to more appropriately order head CTs, which means that we need to be responsible and intentional when we order head CTs. We do not need to order them on all patients with head injuries. We do not need to order them on patients who have syncopized. So we really have to be more diligent about who we're ordering head CTs on. And frankly, our healthcare system just cannot afford to continue our current state of practice. So what is mild traumatic brain injury, and how do we define it? Usually patients come in with the more mild form of head injury, thankfully, and that's 95% of the injuries. Usually they have a GCS of 13 to 15. They may have had loss of consciousness, they may have not. And being that head injury is a spectrum, they may have a mild head injury or concussion, or they may have a subarachnoid bleed or a subdural bleed or a cerebral contusion. So how do we care for these patients? First, it's important to know what the mechanism of the head injuries include. Could this have been from a motor vehicle collision, which usually results in the coup contra coup injury from acceleration and deacceleration? But there can also be direct trauma, such as football injuries or other sporting activities. There can be penetrating injuries, blast injuries. And why we care is because there's damage to the nerve tissues. They get stretched and they tear, and these effects can go on for weeks afterwards, and leaves the tissue very vulnerable to either potential re-injury or potential damage. So this is why we care. This is why it's hard to have those conversations with parents or patients in sports and say, hey, no, you can't go back to playing football tomorrow. This is why. But it's difficult to have those conversations when you are making a clinical diagnosis that the patient is not really well informed, and it doesn't really translate very well. They usually feel that their symptoms haven't been taken seriously. They haven't really been heard. We didn't really care for them because we just said, hey, you have a concussion, don't get hurt again, and follow up in the concussion clinic. So the symptoms that they present with can range from headache, confusion, loss of memory, vomiting, tinnitus, fatigue, kind of foggy brain. And then there are more longer term effects, and we usually talk about this as post-concussive syndrome. And memory issues are the #1 complaint, difficulty concentrating. There can be sensitivity to light, sleep disturbances, mood disorders that go along with it, loss of taste, smell. So how do we navigate these challenges in our busy emergency departments every day? And what we typically do is break things up into 2 questions. Do they have a structural injury, which means do they have a brain bleed, or do they have a functional injury, which means do they have a concussion? So how we address the brain bleed is usually we get head CTs, and as noted earlier, we are getting 4 million head CTs on 4.8 million ED patients who come with that complaint, which means we're not really doing a good job with our head CT rules, be it the Canadian head CT rule or the New Orleans criteria. We're not translating that very well into our bedside practice because we're ordering a ton of head CTs, and 91% of them are coming back negative. And this leads to high wait times. You can see more than 3 hours, increased radiation, and like we talked about, increased costs and just overall dissatisfaction. And there's also not a standard way to talk about concussion with patients. And like I noted, that leaves them feeling dissatisfied and not heard. And it's hard to answer the questions of when they can go back to sporting events or not, because we don't really have a measure or a grade system to answer these questions within the emergency department. BrainScope has helped intervene as a bridging tool where we can talk about if a patient has a structural injury and would need a CAT scan, and we can talk about does a patient have a concussion. So BrainScope is a handheld device. As noted, it uses EEG technology with an AI algorithm that within 10 minutes or so can give you an answer if a patient is likely to have a head bleed or not. And it can give you an answer of if they have a significant concussion or not. As you can see on the picture, electrodes are placed on the forehead, the temple, and the earlobes. And it is connected to this transducer that's laying on the patient's head, and that connects directly into the handheld device. It is user-friendly and easy to navigate. The results that come up are first a structural injury classifier, noted as SIC, and that comes back as positive, negative, or equivocal. If the SIC comes back as positive, that means the patient is likely to have a head bleed. They're likely to have a positive head CT that shows a structural injury. If the SIC comes back as negative, that means the CT is likely to be negative and that the patient does not have a structural injury. And the sensitivity is 99% for even just 1 cc of blood in the brain, and that is tremendous. We have a second result, that's the brain function index score, and that comes up as a percentage from 0 to 100. If the score is less than 50, then that means they have a significant concussion and they do need to follow up at the concussion clinic. If their score is between 50 and 100, we consider them to have a normal brain function index and they do not need to follow up at the concussion clinic. The concussion index is used on patients that are 13 to 25, and the advantage of this algorithm is that it can be used over a span of time. So let's say a patient is involved in soccer and they get a baseline read of 80. That's a great concussion index score. And then they sustain an injury later, then we would be able to measure their concussion index at the time of injury and weeks after. And therefore you can see how is that patient recovering and are they ready to return to sporting activity. In the emergency department at Fairfax, where I work, I usually work with adults. So we use the inclusion criteria of age 18 to 85, GCS of 13 to 15, and they have to have had a head injury within 72 hours. This is a busy slide, but it's actually pretty simple. It starts with the assessment of a patient that can have BrainScope utilized on them, again, with the age 18 to 85, GCS 13 to 15, and trauma within 72 hours. If they meet that inclusion, then you perform BrainScope. If it comes back positive, then they need to get a CAT scan. If it comes back negative, then you assess their brain function index score to decide if they need to go to the concussion clinic or not. So if they have a BFI less than 50, they get a concussion clinic referral. If it's over 50, then they don't need that. And both those patients can be discharged safely, knowing we have a 99% sensitivity of even just 1 cc of blood. If the BrainScope comes back equivocal, then it is up to the provider's discretion to order a head CT or not. Now I'd like to talk to you about the pilot that we did at Fairfax Emergency Department. It was conducted over 6 days, and there was 19 BrainScopes that were performed. In our pilot, our intention was to see if BrainScope can be adopted into our culture and if providers would feel comfortable ordering it and utilizing it, and would the nurses and techs feel comfortable performing BrainScope on patients, and how do BrainScope patients feel having BrainScope assessed on them. We wanted to see if there was going to be a decrease in length of stay, and we also wanted to see if we were ordering less head CTs since ordering BrainScope. The results of the study were overwhelmingly positive. We were actually able to show a 60% reduction in head CT orders. Of those 19 patients that we ordered BrainScope on, 10 were negative and did not need a head CT. 6 came back as an SIC positive, and those patients did get a CAT scan. It's important to note that there was a patient who would not have gotten a CAT scan if it were not for BrainScope, and that patient did in fact have a head bleed that would have been missed. There were 3 patients that we were unable to complete the assessment on. One was heavily intoxicated and wanted to stop. The second had a lot of anxiety and also we needed to stop. And the final one had a lot of muscle artifact, and we were unable to collect sufficient data. We were able to appropriately send 50% of the patients to the concussion clinic. So we did not have to send the other 50%. And usually when people have the head injuries and they have concussions, we send a lot of people to concussion clinic. And this felt good to only send the patients that actually really needed to be there. The results of BrainScope were obtained within 16 minutes, which is a profound improvement in comparison to the potential 3-hour wait when we typically order head CTs. So that is an extreme improvement for length of stay for our busy emergency departments. If we can get a patient assessed in 16 minutes and comfortably say with 99% sensitivity, you don't have a structural injury and you do have a concussion or you don't. Of course, this would make for improved length of stay. It would make for improved throughput through the emergency department and more optimal use of our resources. We were able to survey the providers and the patients. We got 100% satisfaction from patients. In fact, some patients wanted to take selfies during the process because they were so excited to be part of this new technology. In terms of the providers that we surveyed, they consistently said they would use BrainScope and that it did help them assess if they needed to get a head CT or not, and that they would continue to order it, and that they also like the concussion profile to have a more informed discussion with patients. Now, how does BrainScope perform in comparison to our traditional head CT rules, the Canadian head CT rule and the New Orleans criteria? And as you can see, BrainScope performs very well with a 99% sensitivity and a high specificity of 52%. It's important to know some differences. For example, with the head CT rules, patients are excluded if they're over 65, if they have alcohol on board, if they they are on anticoagulants, and none of those are factors for BrainScope. Also, if there's trauma above the clavicles, say a hematoma or lacerations, but as long as the electrodes can be placed on patient's forehead, we can still perform BrainScope. So some of the limiting factors of the head CT rules are not applicable for BrainScope, and that is a huge advantage. For the concussion pathway, I think talking about the BFI and what it can offer in terms of conversations with patients is important. Patients like having a printout and seeing the score for themselves, and there's a graphical representation where they can see where they fall between 0 and 100. And we have more informed conversations. For example, let's say a patient has a BFI of 18. We could say, yeah, it definitely makes sense that your symptoms are presenting this way. You do have a concussion. And patients tend to feel more satisfied hearing that their symptoms are valid. They feel listened to, they feel more cared for, and they have something tangible in hand. And that is far better than what we have today. I wanted to show this graphical representation in closing of the concussion index because it shows on the continuum of time that you can have a starting concussion index of 80 and then at the time of injury how far the concussion index can drop, but also the benefit of having measurements over time and showing the return to baseline and a more informed conversation at that point to say, hey, you've nearly returned to your baseline. Yes, you can return to playing football, or no, you can't. Your concussion index is still too low. You can't return. So I believe that our pilot study was successful in showing the many benefits that BrainScope has to offer as a point of care test at bedside that quickly can answer if a patient has a structural injury and can allow for more informed decision making in terms of head CT utilization and informed discussions when it comes to concussion and the need for follow-up. Thank you very much for your time. I hope this has been informative. I hope that you enjoy the rest of ACEP.